I am going to reintroduce your main host, the lady of the hour, Mrs. Sandra Igwe.
Thank you guys. I hope you're all well fed like I am now. If you guys follow me on social media, you guys know that I'm a massive selfie queen. So can we just take one selfie if that's okay? Yeah? And we're going to shout the Motherhood Group, yeah? 3, 2, 1. The Motherhood Group! One more time. The Motherhood Group! You might see yourself on the screen soon. Right, we're going to go straight on to our next speaker. So the schedule's kind of changed a little bit because our next speaker is running late. So we're going to go on to our second main speaker for today. And she will examine how Black maternal health through a human rights lens is imperative. She will explore how feminist perspectives can drive meaningful change in healthcare systems. And this reframing is essential for addressing structural inequalities. Please help me welcome to the stage Dr. Shola Mos-Shogbamimu.
Okay, is it on? Oh, thank you. Hello, sis. Hello. My sisters, I said hello and you're looking at me anyhow. Hello, my sisters. Hello, hello, hello. I see they fed you. Please let the Nigerian enemy speak. When I have food in my belly, it's all, I'm like the naughty professor, it all comes out. I am so excited to be here. Are you excited to be here? Yeah. All right. Now, everything Sandra said I'm going to speak about sounds like a lot of English grammar. And she's going to be examining and bring the impact, or, just all the big words. I'm like, okay, we will get to that point. But first of all, would you do me a big favor? I want you to look to the person to your left and the person to your right and say, can I be me? People, say it like you have conviction. Eh? Say it like there's something rattling under your... Come on. Can I be me? Thank you. There is so much about being a Black woman, and the fact that they try to impose all these negative stereotypes and they try to create boundaries on who we are. Today, starting from now, I don't know what you've been doing since the 1st of January 2025. But I'm here to tell you that today you're going to snatch back your power the same way you snatch back that waist with your shapewear. Can I be me? Can I be me? Let's do it, because right now I want you to stand up for me. This is Yoruba. Dide, get up. Get up. And in the spirit of boldness, in the spirit of understanding who you are, please, please, please increase it. People, now take the beat. Come on. To the left, to the right. Let me hear you say. Hey! We are miracles. We are miracles. The fact that we're standing here, in spite of all they've done against us. Say, I'm a miracle. 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 Hey, hey. That's like you really are. Check what the Lord has given you. Thank you. One more time. Put your hands up in the air. Wave it like you just don't care. Woo! Hey, 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 hey. Let me hear now. Oh! Thank you, my sisters. Thank you, thank you, thank you, thank you. Thank you, thank you, thank you. Because for too long, they have tried to define who we are as women, as mothers, as wives, as sisters, as friends, And we're saying to them, hell to the freak no. I don't know about you, but I tire. You know when you say like you're really tired? And I am tired. You know, sometimes there are not enough words to encapsulate how you feel or what you're experiencing. So, I mean, if you're Nigerian like me, you go, yay, all of those things mean different things if you understand the context. And you and I know that as black women, we have exhaled and inhaled all the ahs, yays of all kinds of things. Am I right? Yes. So I need us to understand that now has to be the time that we understand fully and start to manifest the truth of the matter, which is that our health care is our human right. Hello? Am I just blowing grammar? Our health care is our human right. And it is time for us to take it to that extent that you speak authoritatively. Oh, let the Nigerian in me speak. Authoritatively. Put emphasis into it. Because, you know, when you're speaking very English, it kind of sounds very, so this is really authoritatively. But when the Nigerian puts the accent and the emphasis, you know there's something happening, something is cooking. The point of the matter is, for too long as mothers, especially as black mothers, we are being made to second guess ourselves, doubt ourselves, even question whether or not what we want for our children or what we want for ourselves as mothers is right or not. Why is that? Why is that? Why does it have to be different for us? And for some of us, you know, let's be honest. I'm a mommy of 3 girls. God is good. I call them my diva, drama queen, and diva-esque. My husband says I shouldn't complain because apparently they're mini-me's. I don't understand. I mean, to be fair, the only thing I asked God for when I was pregnant with them was, in fact, it's a conversation I had with them. I said, whoa, as you're coming, the fees for your school, we need a new car. I made all this list to that. I said, look, better ask God sharp. I have my own list. You ask God for what you need. And then I said, look, just don't come with your father's nose. You can look whichever way you like. But of course they did come with his nose. A modified version, we thank Jesus. But his nose they came with. The serious point that I'm trying to make is that I think for too long when it comes to black maternal care, I think that as women, especially when it's your first time, there's so much we don't know. I swear to God, I don't understand why people do not understand this fact. The fact that you're able to give birth is a miracle in itself. The fact that you went through that whole labor process is a miracle in itself. And some of us have had such traumatic experiences. And that's before you involve the people who make it even feel worse. So whether you're a mother because you gave birth, whichever process it took you to be a mother, the bottom line is that becoming a mother, I think it unleashes the lioness in you. You know, there's only so much BS I can take for myself. But when it comes to my kids, the girl is off. The scarf tied around my waist, earrings off, like, let's go. Because all of a sudden, I thought she was well educated. I am well educated. In defending my own. All of a sudden, all of those parents, well, this is how we behave. Not concerning my children, no. And I think it's really important that as women, and I think women, look, we are all feminists. And I'm not talking about the Western definition of what feminism. Please, let's pack that one to one side. Because feminism existed long before white women's feminist movement, became a thing. All across Africa, African women were leading homes as businesses. They had not just their farms, they had all kinds of things. They were the ones raising their kids. We know what feminism is. We know what women empowerment is. But we get to a stage, especially when you're in the West, where here, with the way the patriarchy works, which is really not that different from Africa, Because in Africa, hello, Africa is a continent, not a country. Thank you. I just had to say that. Because there are different cultures, different languages, but there is that embedded patriarchy in which we navigate. So even here, we have to navigate that patriarchy. But the reality is that as black women, it's twice as hard for us. And that's the way the system is created. So I want to encourage you, my sisters, be you black, brown, and white, that this has to be the time that we work together collectively to change the narrative. What does it mean to be a bold black woman? What does it mean to be a bold black mother? What does it mean to be a bold black with all of the caps that we have to wear? Because, I said this to my kids before. I said, I wish to God you came with a manual. I swear to God, I wish you came with a manual, because I'll just go to section G, paragraph 2, 1.1.1. Hey, what am I supposed to do here? Because this girl is giving me headache. I've explained it 1,000 times, but, well, mommy, I don't think you thought that through. Excuse you? I've been on this earth longer than you, only for my kids to teach me things that I did not know. There's a whole language out there. But our power and our boldness lies in our confidence to speak up and stand up. Repeat after me, then you can take it to the bank. Our power, say it after me. You people are making me repeat. Our power, our boldness, lies in our confidence. Now, who here understands that confidence is not an emotion? Put up your hand. You're in a safe space. Confidence is not an emotion. It's action. Sometimes it's when I've done something that I go, oh my God, what did I just do? But in that hour, in that moment, people might go, oh my God, she really knew what she was doing. No, I was in the moment, people. And usually when I'm in my moment, I'm just really seriously pissed off about something. That's what triggers me into action. Because if I'm very, kumbaya, my Lord, kumbaya, nothing is moving. Kumbaya, my Lord, because I'm very, peace to the world. Thank God. Oh, wonderful. But when I get to stage of, who the hell I have, okay, please, let us start to tear singlets. Let's start to make things happen. But everyone gets triggered in a different way. And I say to people, your confidence comes from your action. We are all made differently. We're not all meant to be. I know they like to say, black women are loud. Oh, you can be black, brown, or white. Oh, you're being too loud. You don't need to be loud to have impact. But if you're naturally loud, get louder. You don't need to be quiet to have impact. But if you're naturally quiet, I swear to God, the force of that quietness will be as powerful as a tsunami. So get into it. But don't be afraid, because I think that is our biggest thing. I don't know about you. I know people talk about imposter syndrome and all of that. Yeah. It's not imposter syndrome that, gets me quiet sometimes. Sometimes it's just a thought, but can I really do it? It's a thought. And the fear I'm having may not necessarily be for me. I don't know about you, but have you noticed, maybe you feel that way, when it comes to you, your personal fear to do something might cause you to procrastinate, or it might paralyze you a bit. But when it comes to your kids, there is nothing on God's earth that will stop you from moving. Nothing stops you from picking up the phone, from going to that school, from doing what you need to do in the workplace. You will do it. And that tells me a lot about who we are as women. That there's so much work we still need to do as feminists, as black women, and just as women in general, to speak to our inner self. Do you have that conversation with yourself sometimes? Oh, if you don't, I encourage you to. Because I have to. Because Shola doesn't listen sometimes. So even when my husband tries to talk, So I have to say to myself sometimes in the mirror, Shola, are you the only one? What is it? What are you annoyed about this time? What has happened? What is it? Or another time I just go, Now pat yourself on the back. We did that. Sometimes you just need to have that conversation with yourself. And ladies, I think part of being confident and being bold is also understanding what you need to let go. Say to me, let go. Let it go, let it go. Yeah. And the things I'm asking you to let go are the things that you need to do to unpick your learning. Woo! Did you feel that? It's like the Spirit came in and said, let me save you. You need to unpick your learning. Because sometimes when you analyze your fear, that fear is rooted in something, someone, somewhere, someplace. You need to dig deep and find out what it is. And then the same way you deal with anything that you don't want in your life, the moment you understand what the problem is, you can address it and deal with it, correct? So in a world that says to black women, you are too loud, you're too dominating, oh, I'm sorry, I think we find you a little bit problematic because we can't contain you. I was not created to be contained. Please, people, let me preach. I was not created to be contained. Do I look like a container? Why would you think you can contain me? Do you know where I am from? What I've been through? Were you there when I shed my tears? Or when I bled red blood? Were you there? No. My friend get here like I said, nonsense. Hey, I can't contain you. Contain me. The point here is, listen, people, I want to encourage you to let the real you come out. Again, ask yourselves, can I be me? Whatever it is they tell us, especially as mothers, mothers. When that child was coming out of my punani, were you there? When I had to go through the stuff, were you there? Nonsense. The same people that tell you that this is how you should behave as a mother, who will try to challenge you, question your integrity as a mother. They will point fingers. They're not there to support you or help you. All they want to do is judge. That's okay, I can handle your judgment as long as you can handle what I blow back with. No, I think it's time we take that stance. Don't be afraid to educate yourself. I said don't pick your learning, but you also have to educate yourself. What is it? For instance, some of us may be going through stuff with our kids being, diagnosed with certain medical conditions that we never heard of. Even in our community, we don't talk about these things. Educate yourselves. So that when they are trying to place a label, you can say, I reject that in Jesus' name. Now, break it down for me. Provide me evidence. How in this case does my child fit this profile? Based on what? You need to challenge things knowledgeably, authoritatively. Are you hearing me? And people, sometimes we will get it wrong. That's okay. Remember, they didn't come with a manual. I don't think God was saying, remember that the Bible says, I don't know how many of you are Christians, whether you're Christians, may the Lord bless you. The point is, children are a heritage. They are a blessing. But they are also part of our personal journeys. They shape and they strengthen us. Shall I remember to say that next time so-and-so says, but mommy, I don't remember that in that moment when I'm like, what the heck is this child talking about? But sisters, as I have only one more minute, I hope to God that you're feeling strengthened from this conference. I hope to God that you understand that you are valued, that you as an individual, you're not just a mother, you're not just a wife, you're not just a sister. You are you. You are a miracle. If people knew what you have been through and where you are from, what you've had to see, the choices you've had to make, you are a miracle. If they understood the plans ahead that God has made for you, what eyes have not seen, what ears have not heard, you are a miracle. Don't let anybody tell you otherwise. You sweep that hair. You step in to whatever you want to wear, snatch that waist because Jesus is Lord. And you take your step. 1, hello. 2, I am. 3, a miracle. Thank you so much for having me.
I'm still fangirling Dr. Shola, yes! Now on to our next keynote speaker. She has broken barriers as the first black woman elected to British Parliament for over years. For over years, she has championed health equity and advocated for marginalized communities. Please welcome to the stage, Diane Abbott, MP.
Can you hear me? Yes. Very good. I'm very pleased to be here speaking at this very important conference. And first of all, when we are talking about black women's health, we should remember that it is black women who helped build this health service. My own mother was a nurse. I was with a friend yesterday. Her mother was a nurse. There's a whole generation of us whose mothers came here to nurse. And sometimes people talk as if we as black people are takers from the public service. But actually, we have helped build this public service. But we are here specifically to talk about black maternal health. And you've had some very exciting speakers, and I only hope to measure up to them. And I hope I'm not giving you facts you've already heard. The situation facing black mothers is so severe, is so severe that in the United Kingdom today, a black woman giving birth is more likely to die than the average woman giving birth in 1965. So many areas of healthcare have moved on and improved and taken advantage of new ways of helping people with their health. But black women have gone backwards. Black women in Britain are nearly 4 times more likely to die during pregnancy and childbirth than white women. 4 times. Let that sink in. If that number was halved tomorrow, it would still be an outrage. If that number was quartered, it would still be unacceptable. And yet, for decades, the disparity has barely shifted. Let me be clear, and you may have heard this already, black women are not biologically predisposed to worse outcomes in childbirth. Our bodies are not weaker. We are not the problem. The problem is a system that does not listen to us, does not take our concerns seriously, and continues to allow bias, neglect, and racism to dictate the quality of care we receive. We have heard the stories over and over again. Black mothers in pain, dismissed by doctors and midwives, told they were exaggerating, that what they were feeling was normal, that they needed to be patient. Some of them have not lived to tell their stories. Others have spent years reliving their trauma. So we are here to make sure, or to begin the process of making sure, that nobody suffers in the way that black pregnant women suffered in the past and continue to suffer today. It took relentless campaigning just to get the previous Tory government to acknowledge that this crisis exists. There have been reviews, reports, parliamentary debates. We have seen commitments made only for them to be watered down or forgotten when the news moves on. Previous governments have resisted calls for targeted funding to address maternal health disparities. They have said no to investment in the very services that could save lives. They said no to research that could help us understand and tackle the root causes of these disparities. They said no to the kind of action that would have meant that fewer black families, fewer black fathers and children would have to mourn the loss of a mother, a sister, a daughter. And yet, despite the inaction of governments, campaigners and organisers like the women that organised this event today have driven change. It is black mothers who have refused to say silence, and the healthcare professionals who have pushed back against a system that too often tells them to look the other way. Now, with a Labour government, there should be a real opportunity for more progress. And this is the time to push harder than ever to make sure that this government delivers on its promises. We must continue to demand real investment in maternal health care. We must ensure that policies on health inequality are not just words, but are turned into action. We need a maternity system that is fit for purpose. This means better training for healthcare professionals so they understand the biases, the racism that have been allowed to persist in medical education. It means recognizing that the pain of black women is just as real as anyone else's. The symptoms do not present necessarily in the same way in black or brown skin, and a failure to recognise this can be fatal. The government has to tackle the crisis in midwifery, which has left NHS maternity wards dangerously understaffed, overstretched, and unable to provide the care that every woman deserves. The Royal College of Midwives has warned us of this for years, and yet midwives continue to leave the profession faster than they can be replaced. It means funding and resources and a government and health ministers that are willing to put its money where its mouth is, because words will not save lives, including the lives of black women. Now I want to address something else. While we must demand better from our National Health Service, privatising our health service, either by stealth or blatantly, will make health inequalities far worse. You may have heard that privatisation gives more choice, but it only gives choice to the people with the money to afford to pay. For those of us that can't afford to pay, it means the level of care we get will be even worse. We know in countries where healthcare is privatised, like the United States, the poorest communities are left behind. If we truly want to tackle health inequalities, we must not be taken in by rhetoric about choice. We must fight any attempts to privatise the NHS. We must fight for a properly funded, well-staffed and publicly owned health service. In the United States, because access to healthcare should never depend on the size of your bank account. Do you know that in the United States, the biggest source of bankruptcy is medical bills? And the way that some people, even people in my own government, want to go, we could be in that position. For many of us in this room, this is not just a political issue, it is personal. It is certainly personal for me. We know what it is like to be dismissed and marginalised. We know what it is like to watch somebody we love go through a traumatic experience that could have been prevented. We know what it is like to feel invisible. I know what it's like to feel invisible, and I have fought it all my career. And we should not have to share our pain over and over again just to be believed. We should not have to relive our trauma for people to take this seriously. The statistics alone should be enough. The evidence is there. The stories have been told. Black mothers deserve better. Black babies deserve better. Black families deserve better. And that is why I felt it was so important to be with you all today. You know, maternity care is not the only area in health where people of colour are marginalised, stigmatised and ignored. We could have a whole conference twice this size on the experience of black people in the mental health service. But thank you to every one of you here today. Your work, your voices, your advocacy is the reason that we have come this far in this fight, and it is the reason that we will go even further. Thank you.
I just want everyone to just thank this incredible woman. I'm looking at you as such an inspiration. I know this is a monumental moment right now, having the first ever black British female MP. Thank you for paving the way for many of us. Thank you for setting precedents. That's opened doors for all of us now to have our own platforms to collectively speak about these challenging issues, especially pertaining to our race. In the past, we've been silenced, and now we have a voice to speak up and speak out. Thank you. A cheeky Thank you. Someone else. Thank you, guys. So on to our next panel. Our next panel will be discussing the gap between maternal health policies and what actually happens in practice, focusing on how policies can better reflect black mothers' experiences and ways to ensure personalised care. Please welcome to the stage Janet File, MBE, Midwife Keely Grinley, Maria Benedetti, and Dr. Jasmine Leonis.
Janet is an expert in midwifery and women's health policy, working with organisations including the Department of Health and NHS bodies. Then we have Keely, who is rapidly progressed from band 6 to a band 8 midwife, now leading on equality, diversity and inclusion. Maria is one of the UK's first midwives appointed to address healthcare inequalities. And Dr. Jasmine is a consultant and obstetrician appointed as National Speciality Advisor for Choice and Personalised Care, leading on equity and equality.
I have lots of questions, but I'd just rather open it up to you guys to just share your experiences. We're going to start off with Maria. Thank you.
Hello, everyone. First of all, I must say I'm super, super honored to be here today. Thank you, Sandra and the Motherhood Group, for the work that you're doing. Well, I must say, towards the end of 2019, an opportunity came as a secondment for a BAME midwife. I don't know why that name was chosen, but I was encouraged by many, many colleagues to step up to take on that role. Courageously, I did. That was prior to COVID and prior to George Floyd. I took on that role, but I must say it was a very, very lonely journey because there was nobody I could ask for help, no one to share experiences, no other midwife I could call upon, but instead was everyone else coming into me to ask for solutions. But I just thought I didn't have the support, but I did have a distant mentor, Rosa Parks. Do not be afraid to do what's right. And I held on to that. And I really took on the opportunity to try and find what were the gaps within the trust where I work, within the community. And one of the things I found back then was still black women were 5 times more likely to die, which for me, at the same time as I was trying to find a solution, I was also learning for myself, which was shocking, the statistics which matched the national at the time. So what I did, I started working with the community. I went out for 3 months, identifying what the gaps were, because the mandate at the time for me, go and find out why is it that these people are really hard to reach. What I can say is that I discovered they're not hard to reach at all. Actually, we were hard to access. So for me, it was really, really important to come back with some key areas to work on. But what I must say, a lot's been said today, so I'm just going to focus on the aspect of addressing English language barriers. It was shocking because a high percentage of women did not speak English as their first language. And as we've heard already, how difficult it is as a black woman to access healthcare services. Now imagine not being able to speak the language, not having the right access to interpreters, not having someone that can advocate and speak up for you, plus you don't understand, just because you don't understand the language. For me, that was really, really important because when I first came into the UK, I couldn't speak English at all. I had 2 small children, so it was really, really difficult to navigate the healthcare system. So I took upon myself to actually be a voice to these women. So a lot of the work I did was around that, creating a path for them, being courageously the only voice in a room, sometimes mostly by white people that did not understand all these issues, and I just had to be brave enough to initiate those conversations. So one thing that I will say is that it's really, really important if you are in a position, if you are a healthcare professional, if you are now in a position of some sort of authority, if sometimes it's this whole fight, and we know this whole imposter syndrome, this whole lack of representation, that if you do get a seat on the table, use your voice. Use your voice because sometimes you might be the only person that will be the voice for that service user, for that black woman that you're trying to help. So use your voice and do what you can. I don't want to take too much of the time, but there was a lot of work that we were able to do. One of them was, I was one of the co-leads for a project called Creating Cultures. We had amazing NMVPs. I would say really connect with your NMVPs. They were really passionate, and they found passion in the same area I found passion in, and they listened to what the service users needed during a time where continuity of care had to be discontinued, but women still needed a continuity of support. So we created a project where we could bring mothers from the community who are bilingual, and they were able to come alongside service users that could not speak English as their first language and advocate for them. So I would say utilize that help, go with the goers, do not be afraid to use your voice, and sometimes you just have to cover your ears. And just like our sister here was talking about, and I was so encouraged by hearing you. Where were you in 2020? I would have needed your support. I'm not going to say much more. There's a lot to say, but yes, if there's any questions. So yeah.
Keely, please take it away. I know you have your fans here today.
Hi, everyone. I could speak on this for a long time, and I get very passionate and very angry, but it's nice and refreshing to be in a space where I can actually get angry without having that label. So if I want to be angry, I'm going to get angry. Just 2 things that I wanted to touch on. First is, in the NHS, we have something called Res Data, which takes on the experiences of black and brown healthcare professionals in the NHS. And it shows us, it evidences that there's a lack of diversity with healthcare professionals at the top, above band 6, band 7. And I believe that the policymakers at the top, if there's such lack of representation and diversity, I think we're going to have a lot of bias in that. So I think that's a problem. And the other thing I wanted to touch on is my absolute frustration with the APGAR score. So a lot of people in the room will know what that is, but we as midwives, when a baby is born, it's a bit of a scoring system to tell whether a baby is well or not after birth. And we look at things like the reflexes, the tone, and things of the baby, but one of them is the colour. And the only options that we have on our systems, our databases, our forms is pink for well, or pale or blue for not well. So where's the option for a black baby? And that is, the APGAR score was developed back in the 1950s. I think it was in America. It's very, very outdated. And for me, that speaks volumes in terms of the fact that that's still a thing now. And it's my bugbear when I look through notes at work and see that people are writing, midwives are writing pink for black babies. So how well have you done that assessment of the baby then? Because that baby's not pink. Yeah, in terms of policy though, I think that there's a real lack of specifics in policy. I feel like the trust that I've worked at, our policies promote equality, where we're doing everything the same for a white woman, a black woman, a brown woman, or babies. People need to know, midwives, healthcare professionals need to know the difference between equality and equity. If we treat everybody the same, given the fact that a black woman is so much at risk just because of the colour of her skin in maternity, we're actually going to cause harm if we treat her the same as we do for white women. So I think it's really important that our policies are scrutinised at every trust with an anti-racist lens. And if has your trust got an anti-racist policy? And if they don't, why not? That's something that you could take to seniors and ask them why. Because how can we be anti-racist organisations if we've not even got an anti-racist policy in place?
Thank you. Janet File.
Okay, so as I was sitting here, I was just thinking about what I can do to induce the Right Honourable Diane Abbott to come and work for the Royal College of Midwives as their PR person, because she spoke so eloquently about the problems facing midwives and midwifery. But seriously though, I do work currently for the Royal College of Midwives, but would also like to assure you that I was not a DEI hire, okay? I got there by the sheer strength that I don't always consider myself to be a midwife. If people ask me, the first thing I say is that I'm an activist. And I'm just going to say to you why I think I'm an activist. So if we go back, I'll just say to you, with the collaboration of many people in this room and many organizations, we've changed 2 laws in this country. We've highlighted mental health issues for pregnant women, particularly black women, because there's a stigma around it. And in my work with the Royal College of Midwives, we work with the Race and Health Observatory. Just notice that I'm just saying we. I'm not going to say me. I'm going to say we, because there are many people in this room. And I was talking to my friend Gita outside, and I say, I don't want to come and sit here because I don't want to say what I do. I want to say what we do. So there are many people in this room that I've worked with, and trust me, we've changed a lot of things. But to the midwives and to the mothers in this room, I want you to know that we've done fantastic work. It is not, you see, midwifery is a women's profession. And we need to think about the people who hold the levers of power. Firstly, how they perceive women, like Dr. Shola said earlier on. And secondly, how they hold on to power, be you black, white, but when you're at the top, you don't want to let go. So midwives are women. A lot of midwives come to the profession to do a lot of good. So when we're sitting in places like this or outside and we're talking about midwives, I'm not saying people haven't had negative experience. We need to think about the fact that if we continue to kick them, it's going to come a day that there won't be any of them, because the powers out there that are saying to you the midwives are like this, they're like that. I'm not defending anyone, but I really want you to think about that. So back to the work that we do within the Royal College of Midwives. So when you think about the way the instruments and the policies and the drugs and everything else is used on black women, it is seen through a colonial lens. So one of the pieces of work, before you ask your question, Sandra, I'm just going to. One of the things the Royal College has done is around decolonizing midwifery education. You need to start with the midwives in training and also decolonizing midwifery practice. So when you go downstairs for your cup of tea, please look at this, go to the midwife stand. And another thing we have done, this is my opportunity to promote what we do, is more and more in schools and also in health facilities, There are people who are neurodivergent that are turning up, and people are dismissing them. So, I mean, kudos to my organization. Look, I tell them as it is. You know, I don't always say what it is they want to hear. But we've done something like this around neurodiversity. So please look at it. I mean, as a midwife and an activist, that's my first job, activism. During COVID, we were all out there with people in this room, Tommies. We went to Peckham, we went everywhere, doing safeguarding and women's health workshops. And I think that we recognize, well, I recognize the inequalities and the gap between health and well-being and outcomes for Black women who are pregnant. We work with the Race and Health Observatory, and you're talking about skin color, and we have done that research and put out guidance around neonatal testing, especially the APGAR score that somebody mentioned. And we've also done an awful lot of work around communications, advocacy, and language translation. Because if you have a woman that turns up that cannot understand what you, the midwife, is saying to her, how do you expect to give her any good care? And that is not really in the gift of midwives. Remember, we are women, so you need to stand with the midwives to campaign and activate for what you think needs to happen for Black women. I'll just stop here. Thank you very much.
Dr. Jasmine Leonis.
Thank you, Sandra. I'm totally humbled to be here amongst all of you. And again, comparing to Diane, Abbott, and everybody else before me, I feel I'm going to compare. But I stand as an obstetrician, as a Black obstetrician, and really proud. And seeing you, being here with you as a national lead, as a specialty advisor for choice, personalized care, equity, equality, this is where I feel I belong. And I feel it's been a calling, and this is the work I'm passionate about. I was a consultant, I'm still a consultant at Eastern North Hertfordshire NHS Trust, and was a clinical director. And again, during COVID, it brought home a lot of the disparities. We knew about what the statistics are, and really at that time formed ethnic minority work group during that time in my trust. And in the East of England, and we formed a minority ethnic group to really look at our workforce. Because again, if we don't look after our workforce, our well-being, the inequalities they face, the racism that exists, how are we supposed to look after our women, our pregnant women in front of us? How are we supposed to do that? And that is the policy and the mantra that I come with, and you would have heard a lot from Wendy Oliwala, our National Equity Lead. Again, we have to think of our workforce, our midwifery workforce, obstetricians, neonatologists, and that's what it's really about. And I became a National Maternity Improvement Advisor, working with trust, looking at leadership, looking at culture, going to speak to women, our Black women, looking at how we represent our maternity and neonatal voices partnerships. We know representation is lacking from voices like you in terms of developing policy and developing strategy. And that's what my role is, certainly within the team. And in the last year, I became a National Specialty Advisor for Choice and Personalized Care, which I thought this is really where I belong. I work as part of the policy team, and again with our National Lead for Equity. And we work with multiple stakeholders, and certainly delighted to be here. We need groups like Motherhood Group, Black Mothers Matter, charity groups, VCSEs. We're all part of the change. It's not a role for just NHS England. We cannot combat and improve maternal outcomes without a joint multidisciplinary stakeholder approach. That's the only way forward. And I believe that in terms of what we're trying to promote from personalized care, we're trying to define what it means as a personalized care, what matters to me, what matters to you as Black mothers and staff supporting women and families in that space, what matters to you. It's about providing that safe space, that psychological safe space for you to come to us with problems as professionals. And we also need to listen as a matter of what matters to you. We also think about personalized care as having supportive systems to support personalized care. We've been talking a lot about staff education. We said not just training, but staff education. And we've been rolling out personalized care training and educating staff. Some of you would have had consultations in clinic. Did the obstetricians ask you, how many of you put your hands up when you entered that room and said, well, what would you like to talk about today? Hands up. Okay, and this is the direction we want to promote. It's about what matters to you, how we have these conversations, how we as a national team can support these personalized care conversations in terms of delivering that care, and not just about having a personalized care plan that you write down, it gets hidden on a computer, different people have it, we know it's fragmented. It's not a piece of paper. It's about the experience. It's about your experience. And that's what we try to share as a message for personalized care. The informed decision making, we talk about shared discussions, shared conversations, but informed decision making. The decisions lie with our service users, you as our Black service users, whether you're white, your social circumstances, your mental health, looking at that holistic approach. This is what it's about. So some of the gaps we're noticing in personalized care, people think it's a midwife thing, it's nothing for the obstetricians, we're not involved. Is personalized care something on the side? Personalized care has to be integral to every single thing that we do. All our policies have to have equality and diversity, personalized care integrated into it, and we're working with all our colleges. Our service users need to understand what these policies are. First-time moms coming into our services, you need to understand what your choices are, and we can support these choices. And policies that are being updated, whether through the colleges, have to reflect 3-year delivery plan or the national policies. And this is the angle that we need to take it going forward. How do our cultural systems support personalized care? We give money as a national team, exactly, to ICBs for equity and equality. Where's the money? Is it disseminated for equity and equality plans? Equity and equality plans were published in 2021. Okay, a lot of systems and service users don't know about these plans. So we need to have these plans foremost and forefront of all what we're doing. It needs to be on every dashboard, every equality and diversity dashboard. Governance, because equality and diversity is a safety issue, And that's how we're going to make the difference. Address the issues around racism, that's there, which we are trying to do as a national team, and try to roll out programs for racism to address these issues. And it's first and foremost in all what we do. So really personalized care is safe, equitable care, and that's how we're going to make the difference. Thank you very much.
Thank you. We only take 2 questions, so any questions, please raise your hand. Just 1 and then 2. I'm so sorry.
Yeah, I said I was going to start that side because I was neglecting them last time. So which one did you say? Lady in the middle there. Which one is it? This one. Can you stand for us, please? Thank you.
My name's Laura. I'm a midwife, and I also work in a diversity and inclusion midwife. It really kind of hit home when you were talking about kind of about navigating those spaces with the kind of snowy white peaks, and I'm just wondering about how do you, now that you have that platform and you have that voice, how do you navigate it in a way that then can bring other people along, so that it's not then on you as the EDI person to fix all the problems?
Yeah, good question. Thank you, Maria.
Yeah, I think what I would say, and I think I'm speaking from a place of literally there was no one to go to. I was the person people were coming to. What I would say, first of all, get confident, like be bold, because you're going to walk into spaces that nobody's interested. Sometimes there's a lot of tick boxes that needs to be ticked. What I would say is identify people that believe in what you believe in. Because when you believe in something, you believe in it strong enough, it's contagious, right? So I became the contagious midwife, right? Be contagious, talk about it. If you notice one person is interested, literally grab onto that person, have lunch, and make sure that person believes in what you believe in, but not only that, why do you believe in what you believe in? Because then you begin to, what I noticed for me, before I got to certain meetings, after months and months and months, because when it got onto COVID, it became a lot easier. When it got onto COVID, when it got onto George Floyd, oh my days, everyone was then talking about it. And then 5 times more came. Wow, I could bring a report. Yeah, Turning the Tide came. I could bring on a report and recommendation for more midwives to do what I was doing. Then I got bold. What did I do? I was no longer the Bay midwife, because midwives got confused. I was a Bay midwife because, are you here for us? No, I changed the name. Now it's called Multi-Ethnic Empowerment Midwife. And it hasn't changed since, right? So be bold and bring other people along, because when you believe in what you believe in, strong enough, do not change your message, remain consistent, and be prepared to say, no, I'm not here to tick the boxes. And the moment I start doing that, people start following the right people. It might just be a few, but that's okay. 2 or 3 can make a difference, so just go with that. Yeah.
Very quickly.
Thank you. Hi, my name is Amifa. I think it's been wonderful to hear all the recommendations in relation to hospitals, etc. But I think the missing link, especially for black people, is having home births. I think there needs to be more conversation about that, because when it comes to birth, that is when you're at your most vulnerable, and in a way you can be your most real. We see that in the positive and the negative. You know, one of the panel speakers was talking about a woman who was a white lady and said she didn't want a black woman in the room. That is that woman being honest to herself, saying what she felt safe around. So if you flip it over, as black people, a lot of the time we walk around, as again has been said, you know, you're zipped up, or you have to brace yourself to face the world. The safest place you feel, you know, domestic violence, etc., is normally in your house. So if you're giving birth, you need to feel safe. You need to feel loved. You need to feel like you're not fearful of things. Let's be honest. Usually that's in your own house. My first 2 children, I had them by cesarean section. I went back a second time to the hospital, cesarean section. If you ask me, really, was I supposed to have this cesarean sections? I don't think so. But you look at all the reports that I got, of course I was. Didn't matter who I was with. Oh, yeah, of course. So what did I do with this one? I stayed at home. Yeah? So do it.
Congratulations. Well done, you. So that wasn't a question. Was that a question?
It was
about
a semi-question, but
yeah,
you just
a quick about homes.
Yeah.
Okay, so if most of us understand ethnicity and black and brown women, they give birth in a different way, not necessarily hospitals. So we've been conditioned into hospitals. You talk about plans. I was listening to you talking about the NHS and the plans that it has. So if I say half of this audience, I don't know the statistics of the audience. If I say half of this audience are not midwives, and if I was sitting where an ordinary childbearing woman is sitting, I would not understand any of the issues around what the NHS is talking about plans. I just want to go talk to my midwife and say, oh, by the way, I'm pregnant, you know, talk to me about it. And I'll stay where I am until I'm ready to have the baby. I won't have the baby at home. But also the powers that be are the ones who are dictating where women have their babies. So this is why women who are giving birth, there's no law against you not having your baby at home. You need to push us. But our voices are muted. And unless you stand with us, then you will not get the things that you want. So I think home birth, there's no issue around home birth. It is about where people choose to put the funding and who has the loudest voice, who can write in the newspapers, who could complain. So please, you need to stand up for what you believe. We can fight the fight with you, but if we're the only ones, people might think, oh, there they go, they're fighting for home births, this is midwives. That is the discourse at the moment, that is midwives pushing home birth and normal birth. But you need to tell us, you need to stand with us, and then you'll get the things you want. At the end of the day, it's your pregnancy, it's not the pregnancy of the...
Thank you so much, Janet. Thank you. And then very, very quickly, just very quickly, please.
Very quick.
Very, very quickly, and a short answer, if that's okay. Sorry.
Hi, I'm the Foreign News Specialist. So you sit before us all as black women. And as we know, we're all very multifaceted. However, you're also healthcare professionals, probably mothers as well. The healthcare system is on its knees currently, and attrition rates are terrible. As Diane Abbott said, we built the system, we helped to build this system. Now, we're experiencing so much vicarious trauma as people working with black women and being black women ourselves. Are the policies reflective of that? So are we seeing the institutions taking accountability in order to retain the black professionals that are supporting us? Because if they don't, where does that leave us? We're going to see a decline in the progress that we've already made. Is there any reflection there?
Thank you, Leah. Very quickly, Jasmine.
Thank you so much, and really important point. And I think at the beginning, that's what I mentioned. Workforce, really is the most important asset we have in terms of providing safe, equitable, personalized care. So yes, there are initiatives in terms of looking at staff development and in terms of looking at to improve cultural relations, looking at how we create inclusive workspaces for staff. Looking at what appraisals we can look at, having these sort of one-to-one conversations, grow together, so it's about, again, what matters to you, even as a professional. How can we create a better working environment for you in terms of developmental opportunities, looking at how we tackle racism and just general well-being, how teams work together. So that's very important. It will vary in terms of what ICBs or local maternity and neonatal systems. But again, the challenge is moving the policy to the actions. And it's about how we challenge behaviors on the shop floor to try to make sure that we can thrive, and it's not just to exist, but excel in the work that we do, so we can retain our workforce, whether it be midwives, obstetricians, healthcare support workers, and all of us who work to support your care. And that's still a challenge ongoing, but we're committed to this. Thank you.
Ladies and gentlemen.
Can I just say one thing really quickly? I think a big contributing factor towards improving inequalities for black women in maternities, we need to be looking after our black midwives. I think that's so important to mention.
Ladies and gentlemen, Janet, Keely, Maria, and Dr. Jasmine, thank you so much for your time. We're going to start off with Noon. Thank you, Noon, for joining us. I know you sit on the Mum Advisory Board for the Motherhood Group. Could you please share your story and your experience related to the topic?
Yeah, hi everyone. I am really excited to be here today and very nervous. I just want to say, for starters, I moved to the UK in 2021. I'm originally American, and in that time of being here, I have not been in a black space. So this has been filling my cup, and I've been crying in my corner all day long. For starters, I am a birth and postnatal doula, and the thing that inspired me was my experience in navigating my own pregnancy. In 2023, I gave birth to my son at 30 weeks. Navigating the NICU was really difficult for me as a first-time mom, and it's still something I'm unpacking, obviously. And essentially, for me, it was that much more lonely because I ended up having this very traumatic delivery, and it was sudden, and my husband was not in town. My family's in America, and they were scheduled to come out in November when he was due. So I was completely by myself. And navigating the NICU as a black woman became very difficult with nobody to advocate for me. I did not meet my son right away. He was on one side of the hospital in the NICU, and I was on the other in the ICU. And I think that one of the biggest issues for me was that I was one of two black women patients in the NICU, and nobody tended to us two, oftentimes confusing us for one another. So the other black mom was a second-time mom, and I was a first-time mom. So the lactation consultant would do her rounds, and she would skip me, thinking that she already tended to me. And when I approached her about, wanting to understand breastfeeding, she had said that, oh, you already have a kid, so I assumed that, you have that figured out. And I said, no, this is my first kid. And then she said, oh, I must have mistaken you for that lovely lady on the other side of the NICU. So me and the other lady, her name is Crystal, me and her became best friends to this day. She taught me how to breastfeed, and I credit everything I know about motherhood to her, and she's one of the most influential people in my life. She's why I decided to become a doula and why I'm here today.
Wow. Thank you so much for sharing that, Noon. You're extremely brave. Just got some tissues there if you would like to use it. Our next speaker, please. Louisa, it's an honour to have you here. If you would just like to share your experience.
Hi everybody, my name is Louisa, and so my story is I was pregnant 7 times in the space of 8 years. I gave birth 4 times and I got to take home 3 babies. So I had 3 consecutive miscarriages after my first daughter, and then after my second daughter I went into premature labour with my son, and after 47 minutes he passed away. And that was in 2020, it'll be almost 5 years next month. It was very obviously very hard. When I went to the hospital with him, I was just given palliative care. There was no active care given to my son whatsoever. Even when he survived for 47 minutes, there was still no care given to him. And when I left the hospital, I wasn't given any aftercare. In fact, the hospital that I gave birth to my son at the time didn't have a bereavement midwife or a bereavement policy. They do now, because I've made sure of it, but at the time, they didn't. And also when I had my 3 miscarriages, I wasn't given any support. In fact, it was kind of dismissed. I was told that it happens to lots of women, it's nature's way. I was given the test in the end. I was lucky I had a good GP because I didn't actually do the pregnancy test on the 3rd miscarriage. I just knew my body so well, and luckily my GP trusted me because any other professional after him didn't, because they would often make comments like, oh, but we haven't got a confirmed 3rd pregnancy. But I was diagnosed with sticky blood syndrome, lupus anticoagulated. I can't ever say it properly. Alicia, help me out.
That's one of the tests that Tommy's offers at the recurrent miscarriage clinics.
Yeah, so that helped me then go on to have my second daughter. But they didn't, I always thought the risk was before 12 weeks because I was miscarried around 7 weeks. But when I got to 22 weeks and 5 days, according to the doctors, I'd gone into hospital, and I was actually going to see the midwife a couple of days before in the hospital, complaining of bleeding, cramping, pains, feeling uncomfortable. And I showed her a picture of what looked like a plug, and now I know in hindsight it was a plug. But I didn't register at the time that I was showing all the signs of labour. As a midwife, she should have, but she didn't. She sent me home after telling me to swab myself, telling me that she thought I had an onset of a urine infection. And then 2 days later, I had my son. At that point, the hospital where I live, they can't deal with babies under 30 weeks. So as soon as they heard the weeks of gestation, they just left me. They just decided straight away, we're going to give her palliative care, so no active care for me or my baby. Because he was so little, there was no monitoring, and my husband at the time wasn't allowed to come because he'd had contact with his grandmother 12 days before, who had tested positive for COVID. So I was on my own. I drove myself to the hospital. Luckily, my sister was able to come with me, and they then let my husband in after my son died. So he didn't actually get to meet his son while he was still alive. And then I was discharged. They didn't even contact the community midwives to say that I'd lost my son. I still had my 24-week checkup. Call me the week after. So there was no aftercare. I was left with the box from SANS. If anybody is experiencing the things, you'll know about the box from SANS. That's all I had, was just leaflets. We're now nearly 5 years down the line. Since then, in 2022, I started a podcast called Love, Life and Loss, where we talk about baby loss, because I felt so isolated and so alone, and I couldn't really talk to anybody. I felt like it just made everybody else feel awkward, and I ended up consoling them. So I wanted to create a space where I could tell my story and I could invite others to do the same. And then I've just taken it that step further now. So I've now got a company called Zion's Lighthouse, after my son, Zion. So where we will go and support and educate people around grief and baby loss, and support the most vulnerable, and do what I can to support this community, because it is such an issue that it's such a hard conversation to have, but it's conversations that we need to have. If we don't have these conversations, then we won't affect change. So thank you, Sandra, for having me here today to be able to have this conversation.
Thank you so much, Louisa. You have done some amazing things, and I'm honoured to know you. Thank you. Alicia, this is your third time speaking at the Black Maternal Health Conference, so it's an honour to have you back here with us again. Would you like to share your experience and also link into how Tommy can support?
Thank you very much. Good afternoon. My baby daughter's in the corner over there. Hi, baby. So I've been pregnant 4 times, and I have 2 living children. My daughter Eliana, she looks just like her older brother. He was born in 2017, and he was born extremely unwell. We knew he was going to be born unwell because at our 12-week scan, I've never seen such a look of confusion as I did that day on the sonographer's face. I knew something was wrong, but she didn't really communicate that. She just said, I've got to go and get a doctor to come and have a look at this. And this guy came in. Turns out he's like a specialist for reading really early scans. That's literally what he does. He's able to spot problems as early on as 12 weeks. They explained to us that my son's problem is often incompatible with life, and they gave us the option of termination. And I asked the doctor, seriously, what would you do? He goes, I would terminate. And I thought, okay, so do you know for sure he's got this condition? Well, we can offer you diagnostic testing, but that comes with a risk, a 0.1 to 0.3% risk of miscarriage. And I said, okay. Spoke to my partner, and we were like, let's do it. We can't write him off just like that. So I had what's called a CVS, which is chorionic villus sampling, where they numb your abdomen and they stick the longest needle I've ever seen in my life into your abdomen. And what they're trying to do is collect some cells. You can tell that I'm a birth nerd. I love this stuff, biology. They collect some cells from the chorionic villus plate. So that's in between my mother, the womb, my womb, and your baby. And that can give them information about genetic issues that may or may not be there. And I had this done. And I had to wait a week for them to call me to tell me if my son had this condition they suspected or not. And he didn't. He didn't. So they told me he doesn't have this. And I was like, he? So he's a boy. And my partner always wanted a son. He's like, I knew it was going to be a boy. I knew it. And he jumped out of bed and was doing this little man dance. But they still knew he had this other condition. It wasn't the condition, the like 99% terminal one, but he did have a condition. Over the years, I'm probably going to share more about what the condition was, but for now, that's what I'm going to give you, I'm sorry. So I would go for my scans. I was sent to the fetal medicine unit. That's where I had my scans. Every time they printed out a scan report, it would be like, Alicia is aware that there is a chance of stillbirth. Alicia is aware there's a chance of stillbirth. Every single scan. You know, when you look at your scans, you're like, oh, this is how much they weigh. I don't want to read that all the time. Just tell me verbally, one and done. Document that you've told me and stop putting it there. I had my boy in November 2017. I didn't know what was going to happen. All I knew is that I went into labour before I should have done. There was a big splash like you see on TV. I was in the kitchen and then the floor was wet and had tiles in the kitchen, and I slipped and I fell because it was that dramatic. Ambulance came, took me. I was contracting by then. A guy came in who was the surgeon, obstetrician, with the thickest eyebrows I've ever I don't even remember his name. I just knew that his eyebrows were just like this. And he said, we need to deliver your baby in the next hour. So that's what happened. When he came out, he cried like a little kitten. Meow. I just remember that. And then they took him away into a side room where they stabilised him. Then they took me off to recovery and CATS. CATS is Children's Acute Transportation Service. They come for the sickest of the sick. They came and they put my boy in there, and my partner went with him to the other hospital. I'm going to wrap this up soon, I promise.
Take your time.
I'm just like reliving it now. But my partner, and I will always appreciate him for this, Eliana, this is your daddy I'm talking about. He made sure that that ambulance crew came in to show me my boy before they took him. Yeah. because you don't just... He's going to be so chuffed that you clapped for him. But you don't just rip children away from their mums like that. And another thing that this hospital did is they took photographs of him in the stabilisation room and they gave me a card from him to me, and it had his picture in there. So before I got to meet him, that was my first look at him. My son was a fighter. All the literature that I read, I told you I'm a birth nerd, I wanted to read all the literature. You told me that my boy was going to die, you told me that I should terminate. But show me the literature that says the boys that have children that have his condition, what are the survival rates? They couldn't do that. So I tried to look for myself, and it turned out that children of his age just didn't survive. It just wasn't a thing. There was no literature because he was that much of a fighter. He was making history. But in May 2018, he did succumb to the extent of his injuries. He had multiple surgeries, but comes a point, and there came a point for me, where it was like, when is enough enough? When is enough enough? And I knew the end was coming. I asked to see the palliative care team because you know. And I remember the night before he died, I couldn't sleep. And I ended up watching this weird horror movie called Mama, which is a poltergeist who's looking for her lost child. And I was like, what's going on here? And then at 5 o'clock in the morning, one of his favourite nurses, Charlotte, she called me. And I said to her, it's time, isn't it? And she said, yeah. Sandra, when you ask me a question later on, I've got something to tell you related to what I just said, so I'm just trying to park it now.
Okay.
No, I'm going to say it now. Gina, I know you're not here, Gina Reeves. She did a podcast recently with Helena Moraes. And I remember she said when she was experiencing her loss, she knew something was wrong, but she got up out of her bed and she had a wash before she went to the hospital. It's a very Caribbean thing to do. Before you go to the doctors, you make sure you're in fresh clothes, you brush your teeth, you have your breakfast, you're looking spick and span because you don't want them to think. And I think that goes back to we had to present ourselves in a certain way to be taken seriously. Yeah. And I remember I knew he was dying, but I got up and I had a wash and I put on clean clothes because I wanted him to, I don't know why. The conditioning is there. And I can imagine the nurses were like, why is she not here yet? But you don't understand the cultural ties that I have to past colonial things, ancestral things, that ancestral urge to be clean, to be tidy for my boy when I did say goodbye. I've never spoken that much about him, but my little girl's in the room and I swear she's giving me the strength.
Thank you so much, Alicia, for sharing your story. I appreciate you are incredibly brave, even when you don't have to be. And I'm so proud to say that I know you, and I know that your story has changed many lives already. She is the founder of Black Baby Loss Awareness Week. Thank you. Should we take a breather? And then I was going to go on to Montel, but if that's okay, if you would like to speak next.
Okay, hello everyone. Thank you so much for having me here today. So my name is Montel, and I'm the mother to an incredible, brave, strong, resilient baby girl. Her name is Jemima Rose. She is a heart warrior. She was diagnosed with a rare genetical heart condition called hypoplastic left heart syndrome. And so I found out I was pregnant quite early on, found out around 6 weeks, so we had a few early scans, and then waited until we were assigned support from from the NHS. So when we had all of our scans, the early scans up until 12 weeks, everything was absolutely fine, normal, no concerns whatsoever. And this is my first pregnancy as well, so I almost didn't know what to expect. And in ways I'd feel like I did go into it quite naively as well. I mean, I know you hear things all the time, but when you're going through it and everything seems to be going well, you just kind of go with the motions. So everything was absolutely fine up until our 20-week scan. And this scan, it seemed like everything was going okay, but there were points during the scan that the sonographer had asked me to reposition. So she'd asked me to stand up, go to the toilet, drink some water, and she was just struggling to get all the images that she needed. And during this, she was very talkative, which I liked as well, so I didn't think anything of it. She was like, all right, I'm just going to check the brain, just going to check the legs. We didn't want to find out the gender at this point, so she was like, okay, if you don't want to know the gender, look away now. But she kept on going back to the heart area. So she'd say, okay, just going to look down at the legs. Let's check the heart again. And in hindsight, I see now that she kept referring back to the heart. But at the time, I didn't think anything of it. So the scan went on. And then it got to a point where at the end of the scan, she was like, I'm really sorry. It looks like there's an issue with the baby's heart. I'm not sure for certain. It could just be the positioning. So we do need to refer you on to the fetal medical unit to have a specialist scan. So at this point, my heart did drop a bit, but I wasn't too concerned. I was still pretty confident. It was the positioning because prior to that, everything else seemed to be going fine. So about a week passed, had to wait for the specialist appointment, and that was the most daunting week, just wondering what's going on. And also when this sonographer created the report, I saw at the end that she had put suspected HLHS. So at the time I had no clue what that meant. I didn't know about this condition, so I did what you do and I Googled it. And what I saw in Google was just terrifying, like something that I'm just now coming across, and to find out that my baby could potentially have this, and it's one of the rarest congenital heart defects. And yeah, my mind started racing, and then I went onto Facebook and I looked for different support groups, and then I had to stop myself spiraling because I didn't know for sure what it could be. So I had this in the back of my mind. I kind of knew what it could potentially be, and I just remember my thoughts were, okay, how many Black parents, how many Black mothers are going through this? That's where I directed my focus, to try find those support groups and be proactive. So we went to the fetal medical unit for the specialist appointment, and that scan was completely different to anything else we'd experienced. It was very intense. She did inform us that she'd have to be completely silent throughout so she could get all of the images and everything. So at this point, myself and my husband, we was just praying and just hoping that everything was okay. So it got to the end of that very long appointment. It was around an hour or so, and again we received the news. Unfortunately, it's not looking good. We were then taken off into the support room, and we were met with the sonographer, a cardiac specialist, and a support worker. And that's when they then overwhelmed us with information of what the condition was. They showed us diagrams, they gave us statistics, and then they gave us a decision. And the decision was, you either go ahead with the pregnancy, knowing that immediately after giving birth, your baby, if they make it, they will need open heart surgery within the first few days of life. Following that, they will need another at least 2 more open heart surgeries. We were given the option to terminate the pregnancy, and then finally we were given the option of palliative care, just to give birth and allow the baby to comfortably pass away. So we trust in God, and we knew that the only option for us was to go through with the pregnancy regardless of the outcome. So that's the decision we made, and I remember from there everything just turned around. It went from being a happy, somewhat healthy pregnancy to then I was considered a high-risk pregnancy. So now I'm having appointments every other week almost, and during the pregnancy I felt fine within myself. I felt healthy and everything, but knowing this was going on, it was just such a duality that I was experiencing of the two, and every appointment just became more daunting. More facts are being shared with us and more worries being created, and every appointment up until around 30 weeks, we was given the option to terminate. We was told, you can still terminate. And we had to ask very early on we said that's not an option for us, we'd prefer if you did not mention that, but they continued to mention it because they said they have to do the job. So ended up going through the pregnancy, now placed on high risk. We were referred to a different hospital, we were referred to the UCL hospital, and then also Great Ormond Street. And for me, my thing was I really wanted to have a vaginal birth for my first pregnancy. I was terrified of having a cesarean. So I did ask them, you know, what's that going to look like in terms of the birth? And they shared with me that we can try for a vaginal birth, but in most cases it will end up in a cesarean because of the condition. So just to speed this up a bit, at 38 weeks, I went in for my induction. Long story short, found out I was already in labour at the time. I was already contracting. So what turned out to be an induction and me trying for a vaginal birth very quickly turned into an emergency C-section. And yeah, this was the scariest, most daunting part for me. And yeah, having to come to terms with the fact that I'm now going in for the C-section and not knowing what's waiting on the other side. So I got through it, had the C-section, and similarly Jemima was then taken off to be stabilised, and I didn't get to see her for around 6 hours after that whilst I went into recovery. And similar story, they was ready to transfer her directly to Great Ormond Street without bringing her up to see me. Thankfully my husband advocated for me as well, and he was like, thank you. Yeah, so my husband advocated, and he was just our rock between. He was up and down, going to see baby, coming to see me, making sure we was both okay, and he advocated that they come up and at least see us together. So I got to see her for maybe no more than 5 minutes, and it was just heartbreaking knowing that I could not move because I was in so much pain. And I have quite a high pain threshold, but I've never experienced pain like that before, so I couldn't even like reach over to see her in the little baby pod that she was in. So it was quite a heartbreaking moment, and she was then transferred off to start her journey at Great Ormond Street, whilst I recovered in the recovery ward for the next 5 days. So I didn't get to see her properly until around 5 days after, once I was well enough to join her at Great Ormond Street. To speed up the story a bit more, so at 9 days old, she had her first open heart surgery. Surgery went amazing. She recovered really well, extremely well. And we were advised that we could expect to stay in hospital for at least 6 months, and we were on the NICU ward for maybe 3 weeks initially. Then we moved up to the general ward. We stayed there for 4 months, and during that time she had 2 further open heart surgeries. Again, she recovered incredibly from them, and yeah, we were discharged officially in December the 18th, and since then she's been thriving. She's doing incredible. But yeah. And I will just, lastly, for this part, add that her condition is palliative, meaning it's lifelong. So she will have to have further open heart surgeries as life goes on. But right now, she just has given us so much peace, and we have confidence she's going to be incredible.
Thank you so much, Montel, Louisa, Alicia, and Noon. I'm going to go straight into Dr. Ngozi, if that's okay. If you can just share what you've heard today, your thoughts and insights, and how can services provide better care for Black mothers?
Thank you. I just want to start off by saying thank you to all of you on this panel. I'm a neonatologist, so I look after babies who are born too early or babies who are born sick. And when you said you remembered his eyebrows, most mothers, they remember everything. Yeah. And empathy costs nothing. So the amount of times that I come across colleagues, I go to meetings where there's a real lack of empathy. Kindness doesn't cost anything at all. So some of these, they've been really sick babies and no one's taken away from that. But actually, to get a mother to see her baby who is really poorly before you take the baby off, it's a matter of minutes. We brought about that change in our hospital, and it's one of our plans to make it. We've written it up. It's something called a delivery room cuddle, because many of these babies are so poorly, you're not absolutely sure whether mothers will be able to have the opportunity to hold them again. So we started off doing delivery room cuddles in our hospital. It's not massive research, but it's research that matters. It's been written up, and we're hoping that we'll extend that to many other hospitals. And I didn't actually... I actually think that would be a thing. It wasn't something I planned to talk about today, but hearing everybody's stories about how important that time is. So for most mothers, when you get pregnant, you don't think you'll end up in a neonatal unit. But 1 in 7 babies do. There's quite a lot of babies who end up being looked after by neonatal nurses and neonatologists. And we have evidence in the statistics, in the data, that black babies, as we know, this whole conference has been about that, don't do as well as others. And we've been gathering data because I work there, so I see what you've described, that they mistake you for somebody else. There are only 2 black doctors in our ward. One of them's 5'2". I don't know whether you saw when I stood up, but they constantly mistake both of us. Well, that's another story. It's not about me, really. But I always say to all mothers and parents, there are 2 things that you must do as much as possible. Be there as much as you can, because I, as a neonatologist, will probably spend 10 to 15 minutes on the ward round looking after your baby. The nurses are there for 8 hours. And when you come into a NICU, for those of you that have been there, it's very disempowering. It's very noisy, there's lights. You feel not like a real mum, the baby's in an incubator. You keep asking for permission to change a nappy. But actually, if any of you can take anything away from this, it's still your baby. You should be empowered to do all the normal things you want to do. And don't ask, just say, how can I be involved? Because it's your baby. And no matter how many drips they have in, no matter how many monitors they're connected to, you can still do things like change their nappy, give them a clean down, because it's your baby. But as to policy and other things that we can do, Sandra, I just want to say this is just a wonderful conference. It's just wonderful. My daughter is 28 now, and she got married last year. So all of a sudden, the statistics about maternal morbidity and mortality become really real for me now. It's not just data anymore, it's personal to me. And so when I go to conferences and I'm sitting in rooms that we're discussing policy, I think about the impact that will have on my daughter and her family. It's always mattered to me, but when it's personal, it matters just that little bit more. Yeah. So some of the things we're doing, we've set up to make sure that it's not just, I think someone said this morning, I can't remember who it was, that it's about educating, not learning. So it's not just a tick box exercise to make sure that people understand the effects that they have. I hate the word unconscious bias because I think some of it is quite conscious.
Yeah, absolutely. Yeah.
I watch them. Yeah. I see the nurses when they, I think my friend from Bliss is here, and we recently had access to some data about what happens to babies when they're admitted to neonatal care. And I said to them, before you tell me the data, I will tell you what it will show. I will tell you that it will show that babies who are black, because we have this standard that you need to speak to parents within 24 hours after the admission. I said babies who are black, they will fail that standard. And that's what it showed. We need to try and start breast milk within an hour. I said babies who are black will fail that, not because they don't want to breastfeed, but they haven't been told that I can breastfeed a 24-weeker. However, on discharge, black babies were more likely to be breastfed because that means that they considered this to be really important. So all this data I knew because I'll be on a ward round and I'll say to a nurse, have you asked this mum about breastfeeding? I remember a few weeks ago, the nurse said, I don't think she can speak English. Now, it was a Nigerian name, so I knew she could, because how many Nigerians do you know that can't speak English? Yeah, so I knew she could. So it just needs to change. So I'll tell you about the things that we're doing. I've got how many minutes more? I won't talk for too long. Things that we're doing. 1, jaundice. So I saw Helen Beniglia here. Helen, hi, Helen, thank you. Jaundice, we've got 5 minutes, so I've got a couple more minutes, yeah. So jaundice, we know that if you're black, that it's much more difficult to recognise if you're jaundice. And if you have really high levels of jaundice, it causes a condition called kernicterus, which is irreversible brain damage. I was contacted by the National Child Mortality Database last week to say that there's been a signal because they've seen their fourth baby with this condition and they were concerned. All the babies had colour because it's much more difficult to notice this. We've just been given a grant from the Race and Health Observatory. As anybody from Race and Health said, thank you for the grant they've given us to look at, to see whether we can use a bilirubinometer, which is a handheld device I can use in the community that stops you just looking and eyeballing, so you have something objective you can do. So that's one policy thing that we're doing and research into that. I also want to just shout out to the Race and Health Observatory for the neonatal assessment report they did last year. It's been really changing. I was able to get money from NHS England. Yeah, and NHS England we call lots of things, but they do some good. For them to do a framework for pulse oximetry. So pulse oximetry means that you need to be able to see whether the baby's cynosed. A hospital can decide whether they want to do that or not. So what we have done is use the money to do a framework that will now go through all hospitals. So you can make change from policy, and that's what I'm doing. But thank you so much for having me here and sharing this platform with these incredible women. Thank you, Sandra. I think you're just amazing. Thank you.
Thank you guys so much for sharing your stories. We don't have enough time, I'm so sorry, for any questions for this panel. And we do have to go on to the next panel. But thank you so much, Noon, Louisa, Alicia, Ngozi, and Montel. Thank you. Our next panel will be speaking about grassroots leadership, what that actually looks like, and how it's instrumental for improving Black maternal health outcomes. We've seen many groups along the way leading community-led initiatives, driving lived experiences to bring unique understanding. Please welcome to the stage Sona Patton, Gemma Martin, and Fiona Small.
Sona is Black Mothers Matters founder. Gemma Martin is founder of the HG Midwife and Bumps and Baby CIC. And Fiona Small is the founder of YMSN.
Thank you guys for joining the panel today. Fiona, I've been an admirer of your work for many, many, many years. You're not new to the game at all. Please just share a bit about your journey as a founder, but also how community-led initiatives can drive action for meaningful change.
Absolutely. Thank you for having me. Hello, everyone. My name's Fiona Small. I'm the founder of a CIC called Young Mums Support Network, which was set up 13 years ago. I have an almost 14-year-old, so it's my second child. And I set it up. Who remembers what happened in 2011? Put your hands up. Something significant happened. Everybody's hand should go up. 2011? What happened? Yes. So during that time, which was August, I had just given birth to my second child, who was born probably about 4 weeks or so after the London riots. I call them the London uprising. And for me, I couldn't put him back. I was a new nursing mother. I looked at the screen and I saw areas that I recognise. Outside my door, riot police. I was thinking, what's going on? And I always lead with this story because it's very, very relevant to why I ended up on this journey, I should say. And our then Prime Minister used a very offensive phrase on national television. He blamed single parents for what was going on. I thought, how dare you? He was like, single parents are responsible for what's happening. I thought, okay, I'll show you what a single Black parent looks like. Anyway, that's me getting that off my chest. So I set up an organisation as a response. A lot of us that are in this room are responding to situations, wrong or right? Yeah? So when adversity happens or when situations happen, we often need to do something about it. And for me, I wanted to challenge a stereotype, a narrative. Sometimes, even if you Google images of a single parent, I think it's that Vicky Pollard. Do you remember Vicky Pollard? Yeah, that's what comes up. And it's never nothing positive, right? So single parents in the room, or lone parents, or solo parents, whatever you want to call yourself, oftentimes you're not really represented that well. But sometimes situations happen, right? Life happens. So circumstances happen. I always tell people I'm a single parent, not by choice, but by circumstance. So I set up an organisation with the, I would say, determination to challenge a narrative, but also to represent communities that oftentimes are underrepresented. Fast forward, I want to say, for those, are there any founders in the room that have set up CICs, charities? 13 years, over a decade in the game, I want you to know that your experience, your expertise, your knowledge, it comes with a price. We see that the NHS is under pressure, right? We see that there is a need in society. And I want to talk about very much those who don't often, Sandra, I'm going to get onto the others, don't worry, she knows I can see her side-eyeing. That oftentimes, I'm a bit of a joker, by the way, I'm so glad you're laughing, you know, because I think I'm funny. No, listen. No, let me get serious now. So if we look at the wider determinants of health, right, we can see that there's a issue around population health, yeah? We're dealing with a population health crisis. Wrong or right? Professionals in the room? So we need to find solutions, innovative solutions. It means that leadership, social entrepreneurship, NGOs, VCSEs, whatever they want to call us, are very relevant. And I'm speaking to founders in the room. So the little 5,000, 2,000, 3,000, they ain't doing nothing, you know. I'm telling you, you need to really look at equity. And I'm speaking to those policymakers, funders. Like, if you want to be doing some collaborative work, Sandra and I sit on a few boards, panels, alliances. It's very extractive, right? It's very, very extractive. You want our knowledge, insight. You want access to our communities. You want access to our experiences that comes with, we've just had a really deep panel on here. And most of us felt every part of every one of those females that was speaking about their experiences. And I want to say this to say, right, that when it comes to setting up organisations, you're setting them up with the understanding that you want to drive change. But guess what? EDF want their money, yeah, that's gone up. Thames Water want their money, yeah. O2 or T-Mobile, whoever you're with, want their money. And your children want feeding, yeah? So I'm saying this to say, and Sandra always knows I'm going to come with the money, you know, because when it comes to, this is work, whether we have these sophisticated titles or not, this is work. And it comes with a real heavy load, and I'm passionate in this area. I'm dealing with some real levels of poverty. We've got mothers who are homeless. I spent a lot of time over the last 2 years, I would say, doing some advisory work, just listening to the professionals. What are your pain points? You've got perinatal teams, community midwives are saying, we've got mothers who are homeless. They got nowhere to go. We don't know, they're not, the reason why some of them are leaving the profession is because they're not providing care. They're social working. So they're saying, listen, we did not train to be social workers. We trained to provide care. So that's what I'm saying. This is a population health and public health crisis. You've got children being born into poverty. You've got children who mothers who are refusing to leave hospitals because they've got no addresses. You've got mothers being told, actually, we don't have a duty of care to you, but we have a duty of care to your child. So we can call social services and they can come and take your child. We've got mothers leaving hospital without their baby because they got no address. This is England, first world. Yeah? So I'm saying, I'll go on about this stuff because you can tell I'm passionate. Everyone's like, why don't you become a politician? I won't be a politician. Laugh then. Sorry. I had to lighten it up. The reason why I'm saying, I'm going to come on to the rest of the panel, but I just want to say there's a lot of stuff going on. We've got the rising cost of living. We've got housing issue. We've got people's mental health on the decline. If you're looking at the wider determinants of health and the inequalities that exist and you want to bridge those gaps and you want us to be part of reading your reviews and your policies and your research and all of that, which is all relevant, but we need to look at applying that research and we also need to look at extracting some capital.
Thank you, Fiona, for that powerful speech and always keeping it real. Gemma, please share your insights and your experience to community-led initiatives.
So I will just start with, I am a midwife by trade. And I came into midwifery because of my experience with something called high premises.
So before I go into it, I just want to show of hands, how many of you have vomited before? How many of you have vomited more than once in a day? Okay, so as a midwife, I experienced something called hyperemesis, which is debilitating nausea and or vomiting in pregnancy. And I say debilitating is because I lost 2.5 stone in 3 weeks. I went to the hospital when I could barely lift my head because I was vomiting up to 30 times a day. I could barely lift my head, and as I walked into the hospital, I collapsed on the floor. The midwife picked me up and she said, "Where have you been?" And I said, "I've been at home vomiting. It's normal. It's morning sickness, right?" And she was like, "No." She was like, "You're at risk of so much." Didn't realise I was at risk of having a preterm delivery, a stillbirth, having a heart attack. And this is from vomiting, and people don't realise it. So as a midwife, I just try to create awareness. But before you can create awareness, you have to create education. So I saw a consultant, and his advice to me was, "And why don't you just terminate?" So I said, "Oh, okay, right." So I said, "Terminate because there's a defect, or because," he said, "You know, you're really unwell and, you know, you've been vomiting quite a bit. And I just think if you terminate, you know, maybe try come back next year or," and I just sat there and I thought, okay, so he's just saying terminate like it's nothing. Not having known that you're at a high risk of having hyperemesis HG again. And my thing is, if I'd listened to him, my daughter wouldn't be turning 21 in April. And for me, that's a big deal. And that's why I started with how many have you vomited before? Because everyone has vomited. But for someone with hyperemesis, you need that advocacy. You need for someone to speak on your behalf, because it's hard to fight when you don't have no fight left in you. I came into midwifery because the midwife that I had, God bless her soul, she said to me, "Do you want this baby? Do you want to continue?" And I said, "Of course I do." And she said, "I will hold your hand from now till you have that baby." And she held my hand, literally. She came and saw me every night in hospital when I was in hospital. I was admitted for 6 weeks. Believe it or not, I had PTSD, anxiety, depression, and didn't even realise, because I thought it was normal. And there's going to be women out there that don't even realise they have hyperemesis. And it's not just about vomiting. It's about having a nausea. It's about not wanting to open a curtain. It's about, you know, rolling from side to side for 6 months of your pregnancy. I feel like so much was taken away from me. I didn't have those fancy pregnancy shoots and things like that. All I knew was about spitting into a bottle, which is called hypersalivation. And some people don't even realise what that is. It's hyperemesis. You don't have to vomit to have HG. Some don't know that and they don't understand that. So when you go to your midwife appointment and you look depressed and you look unhappy, you're not just miserable, you're going through something. So what I would say to anybody, healthcare professionals, anyone, family members, if you know someone is struggling in a pregnancy with vomiting, ask them how they're feeling. Because there's a thin line between wanting to carry on and wanting to take your own life. And it's important for me as a midwife, I see myself as that professional friend. You should be able to speak to me about anything and everything, and I then advocate on your behalf when you can't. Yeah. And I feel like HG is something that people need to know about and educate themselves about as well. Because at the time when I'm vomited, I don't want to have to educate you, because I can just about hold myself together. And then you've got the mum guilt as well. So if you've got family members and if you've got other children to look after, the guilt eats you up. So by the time you have that baby, you're already drained. And for me, that's why I have created the CIC, because I want to be able to give back to these women that have experienced this. Because when you've had your baby, no one asks you, do you have PTSD? You don't realise. I have PTSD from a pregnancy test. When I see it, I'm like, oh my God. I'm like, oh my gosh. If I start vomiting, I think I'm pregnant. I'm not. Because I know I'm not. But I'm just like, oh my gosh, I'm pregnant. But that's because of the trauma and what have you. So my CEC is going to be for therapists to come and support women, psychologists to come and support women, yoga, arts and crafts, because you need to get your life back. You need to be able to keep going once you've had HG. So,
thank you. Wonderful. Thank you so much, Gemma, for sharing how your own personal lived experience mixed with your professional experience
has now started a CIC for community-led initiatives. Brilliant. Thank you. And on to our final panelist, Sona, founder of Black Mothers Matter. Please share your experience and your insights.
So yeah, I'm the founder and part of the team that run an organisation called Black Mothers Matter. Black Mothers Matter started when myself and two of my best friends managed to expertly coordinate our maternity leaves, and it was good. And naturally, during that kind of shared experience, we were reflecting on our experiences as mothers and as three black women. We didn't have any, our outcomes were fine, our experiences weren't negligent, or there wasn't any kind of high level trauma that we could pin down, but there was a distinct feeling of luck that we all shared that felt quite different to feelings of our white friends and our white neighbours. And I think amongst the three of us, there was, we all felt that the oppression had been much more subtle, so just a series of kind of softer, lighter moments through navigating pregnancy when we were all made very aware of our blackness. And we appreciate that that if you add up enough soft and light things, you have something that is really hard, really heavy, really dangerous, and potentially fatal. And for us, that was a big part of the picture of the situation we were in terms of black maternal health. One of my friends is a clinician, and we were like, okay, she could do something about it. She was a GP. We were like, actually, no, together as three women who are going through this right now, we do have some power. We do have a lot of knowledge. Let's do something about it. And we founded Black Mothers Matter. And I remember distinctly when we first started reaching out to Sandra, who was already working in this space, and there was already conversation about it. We weren't the first, certainly. And Sandra being really supportive and being like, yeah, do it. And we were based in Bristol, and it felt like despite there being a kind of discussion in society about the disparities, there didn't feel like there was much action being taken, and especially in the Southwest. So we were like, we're gonna do some of the action. And our first project was we were able to get a little bit of funding, and we put together some pregnancy support boxes that we put in bits that we thought this would have been a nice thing to receive during our pregnancies. It had some affirmation cards, some kind of body butter, some nice bits and pieces. And I remember kind of the narrative that goes round about black women being disengaged and hard to reach, and kind of getting in my head and thinking, is anyone going to get into this? And I think we got funding for the first 50, and then we put it in on Facebook or Instagram, and in the first 48 hours we had to kind of shut it down, and there was like over 600 people got in touch and were like, yeah, I want this. And we were like, okay, there is a gap, there is a huge need, and I feel like we've got the skills to fill it. And then our second project was establishing a place and a space specifically for black women to come together in the form of a community group. And in our first sessions, I think we had like 5 people come. 4 of them were our friends that we had texted to say, can you come to this group? But fast forward 5 years, we're a team of 8. We have 4 groups a week across 2 different cities. Like, we have hundreds of interactions with black women and their babies, week in, week out. We have events, we have resources, and I'm so incredibly proud of the impact we're having, and what started with a conversation between friends on WhatsApp, and like the power of us ordinary people to really make change.
Thank you all for sharing your experiences and your insights. I just have a question for the panel, and then we'll open it up to 2 questions from the audience. So obviously we're all working in this sort of community-led organisation space, sector, VCSCs, grassroots, whatever you want to call it. How do you think we should navigate collaboration as grassroots organisations when we have similar goals and missions in mind? Fiona and then Sona.
I would say when you're looking at collaborations, it's looking at ensuring that you're aligning with what the agendas are. So what we found is oftentimes there is people set out strategies. Yeah, we can spend a lot of time. Like I've spent a lot of time. I've had to. So for the CEOs in the room as well, it's also good to note, diversify your offer. You don't have to always lead with a founder hat. You can come as a consultant, as an expert advisor. So when you're sitting and they're sitting and saying, oh, we're thinking about these strategies and we need to know about this. Yeah, I can consult and I can join that conversation. Because sometimes as the founder, you're the only one that will be part of those conversations that are not being paid because they're all on a salary. You're there sitting there. So go in with confidence to say, yeah, I can, this is my day rate and this is what I will be sending my invoice for. Can you cover that? We start with the money. We got children to feed, yeah? We got children to feed? Right. We also have to say, sorry, yeah. You know, see how me look good? I have to, yeah, got children to feed. Another thing I would say is when you are, Sandra, stop. When you are looking at kind of what the agenda is it aligned with what it is that you want to do? Because there's often times that they will be focused on, for who knows about the first 1001 days strategy, the early years. So we spent a lot of time, 18 months to be precise, working on, which is 0 to 2, early years for those that don't know. So they've changed it to 1,000. So 0 to 2 is basically 1001 days. So they recognise that there's always been a lens and a focus on early years because it's a very critical time. And you can sit and have lots of conversations, and I get that strategy is important, but when you're dealing with people's lives, like we want to see action, don't we? We want to see how does this strategy then get implemented in practice. We've just heard a very great example of something extremely practical, what mothers need and what they've actually been able to engage with. So if you're looking at support, so for those who are trying to support with housing, and you know, in an ideal world, I'd love to have some housing stock. So any local authorities in the room, I want every borough to give me 5 units, every local authority, so I can start giving out some houses because we've got some homeless children. That side, I'm putting it out there because I'm going to get some stock. But what I'm saying is, when it comes to supporting in those areas, we can spend a lot of time having conversations. It's all right for us because we're happy to be part of those conversations, but I think there's a bigger and broader picture of what does that mean implementation-wise when you are focusing on people's lives, because these are people's lives we're dealing with.
Thank you.
I was just going to talk about collaboration, like the types of collaborations that are possible with the people within this room, and collaboration between kind of Black-led organisations and other people working in maternity. And something that us at Black Mothers Matter try really hard to do, and I actively have to do, is to move away from a kind of scarcity mindset that exists with a lot to do with funding and VCSE sectors, and quite often you're put in situations where you're having to bid for work or compete for pieces of what seems like a small pie, and that's not it's not sustainable, and it's not the most efficient way of working. So I think being comfortable in yourself that this is not a competition, and actually carving out where you are best placed to implement or to act, and how you can work alongside others is a really important part of growing and progressing a CIC or a charity, but also getting to our ultimate goal that we all share of making improvements and making step forwards.
Sometimes it is about capacity, though, as well, because we are sometimes HR, payroll, facilitators, you know, CEOs running an organisation. So that sounds great, but it's also the bandwidth, with all the best will in the world, is not always there. So even those that's emailed me, if I haven't got back to you, apologies.
Thank you. Thank you so much, Fiona. Just 2 questions. Please raise your hand if you'd like. 1, that's okay, Gemma? And then...
Got you in the middle there. Can you please
2.
stand?
Good afternoon. Thank you so much, everyone. This has been amazing. I felt inspired to mention, based on what Gemma shared about your HG experience, about the asylum seekers that I work alongside at the Magpie Project in East London, who seem to have an incredibly high rate of HG and a shocking rate of emergency C-sections and loss. And they don't get to pick their food in pregnancy. They often are given moldy food. They're given all like fried food. It's not culturally appropriate. They're often malnourished. So I just wanted to give a shout out, think about the solidarity that we can have working with Black and Brown asylum seekers and how we can all collaborate given this government's hostile, inhumane treatment of asylum-seeking pregnant and postpartum women. Thank you.
Thank you for that, and you're absolutely right. And what it is, if we can't get right women that speak English and we're not listening to them about HG, how are we going to support women that don't speak English and non-English speaking? Black women, there's such small, if any at all, statistics about how it affects black women, twice as likely to be admitted into hospital because they're not listened to. And again, that rate with asylum seekers, non-English speaking, they're at higher rate of risk because they're not understood. If you don't understand someone, then translate it. It's so simple, but yet it's so hard to understand. If you don't understand something, you're going to look into it. And that's what needs to happen. But while HG is this hidden condition, debilitating condition, no one's going to listen. So this is why I have no problem with my face not fitting. I have no problem speaking up for women experiencing HG or nausea and vomiting pregnancy. And it's the women that don't get heard that I will always advocate for because their voices aren't being heard. So I do appreciate your comment, and it is something I'm working towards, but what we can do is educate ourselves about HG and step in and say to someone, well, if she doesn't understand, how are you treating her? Because you can't treat something that you don't understand or you don't understand. So if she's talking a different language, I question the care you're giving her. Are you really giving her great care?
Thank you, Gemma. Thank you. And the final question over...
Is there one more over this side?
One more question, I think. Yeah, in the front.
Yeah, you stand up for me.
Thank you so much to the panel for the discussions today. I just wanted to find out, I'm a general nurse by practice and pursuing a PhD in the School of Psychology. My interest is in culture, influence on maternal health. And I know, Fiona, you mentioned about funding, if I got you correct. So for the last 4 years, I've been running a small faith Christian-based group with lots of women in it and stuff like that. But I think I want to throw this question to you, Fiona, when you mentioned about, you know, the thousands, 3,000 is not going to make a huge difference if you want to make impact. So I want to find out how, as an early researcher, also linked to a Christian-based group looking at Black African women and culture, where culture is difficult to define. So I'm kind of already having all these barriers. How do I then look at funding that will help my group of women make the most amount of impact for what we do, especially with those barriers?
Yeah, great question. I tell you what, you're in a very great position, especially pursuing a PhD. Do you know the NIHR? Yes. Check out the Healthy Homes Call, right? It's out at the moment, and everybody else can do that too. And also, I want to say, Awards for All are now giving 20k. Awards for All, lottery. You can apply for a grant. The turnaround is quite quick. It used to be 10, but it's a good start. It's a good start. Look at the reason why, when I say 2s and 3s and 4s, I suppose 13 years in the game, I get to realise you start somewhere. Yeah, so just don't ignore, I'm not coming across here like, you know, that helps. Seriously, it helps. Even if it's just to pay for your website hosting and the other bits and pieces, everything helps. Learn how to, you know, they say you have to creep before you run. Yeah, so everybody is in different stages. I think what's happened with an organisation like mine and probably an organisation like Sandra's is that we've got into a space of contracts, so being a subcontractor and having access to multi-year contracts and different bits and pieces. Funding at the moment is become quite an interesting thing, and as you can see, the ICBs are restructuring, NHS England is restructuring, so if you are working with health providers. We was on a systems leadership program very recently. I also have been guest lecturing on a public health course for one of the universities, because one of the modules on that course is young motherhood, another one is on major life events, and another one is on housing. So I'm also embarking on a bit of a PhD journey myself, because I think it's looking at what's a natural founder's journey, and I'm passionate about this space. And another thing I would say is really recognise where you have the most impact and influence in this space. Sandra knows where she needs to position herself in this sector and in her space. That's why she's doing what she's doing. I can't do what Sandra's doing. Do you understand? And none of us can do what she's doing, because this is her lane. And oftentimes, no, not the same way, Sanj. Like, take your flowers, please. Right? And what I'm actually saying here is that we sometimes have to carve our lanes and stay in that lane. Master your brief. Like, know your stuff inside out. When they're coming to you, they're like, I need her. She's that subject matter expert in this space. She knows her stuff. Be super confident in that. Sometimes we're trying to do too much. Master where you're at, and then there's things that you will then find different routes and pathways. If I was going to tell you, I'd be guest lecturing at the university, and the same way I lecture and speak on the panel is the same. I don't sit in their airs and graces, you know. I have them laughing. They're like, wow, this is a great lecturer, but I keep it super real, you know, because we're dealing with grassroots issues that takes that human approach. You know, there's enough practitioners that look over their glasses and talk to us like that. We don't need all of that. We need to be communicating human to human.
Yes.
Nothing wrong with the glasses, by the way.
Can we have a round of applause for our wonderful panelists? Thank you.
Our next panel. This panel will be examining the experiences of Black professionals in maternal health care. They'll be discussing barriers faced, strategies for creating inclusive environments, and how workplace culture can directly impact patient care. Can we please have a round of applause for Annika Allen-Gray and Dr. Annabelle Sowemimo.
Anika is Head of Diversity and Equality and Inclusion at All Three Media, and Dr. Annabelle is Community Sexual and Reproductive Health Consultant at Lewisham and Greenwich.
Brilliant. We talk about diversity, inclusion, all these buzzwords. Both of you have extensive experience speaking about these buzzwords. Could you explain, what does true diversity and inclusion look like in maternal healthcare or healthcare as a whole? I don't know if we want to start off with Dr. Annabelle.
Yeah, so I think for context, I will just give a brief overview. So I'm a community sexual reproductive health consultant at Lewisham and Greenwich now, and I started being a consultant only about a year ago whilst I was pregnant. I just want to say that it's been a really healing space today, because I also, I had nine months ago quite a traumatic delivery, and it was quite a rude awakening because I've been working in this sector for a very long time. And when I come to this issue in terms of diversity, equity, inclusion, I have been working in space for a while, so it's really nice to see quite a few friendly faces here. And I started my own journey working in this sector when I was at medical school, particularly talking about things like female genital mutilation. And I eventually went on to found an organisation called Decolonising Contraception, now it's called Reproductive Justice Initiative, and then I also wrote a book, which some of you might have read, called Divided, Racism, Medicine, and Why We Need to Decolonise Healthcare. So you might know me from that instead. So I come with all of these different hats when I'm talking about things like diversity, equity, inclusion. I'm also a PhD student at King's, studying the experience of Black women with contraception. And I just feel the need to contextualise, because when I look at the issue, for me, it is so multifaceted, and I'm not just looking at it as a healthcare provider. I've got all of these different hats on. And I think when we're talking about it, it often gets reduced to, as we've heard today, about representation.
and the idea that we're going to fix the system by just changing the face of the NHS. And the first thing I want to start on is what Diane Abbott said, which is that the NHS was founded in the same year that the Windrush came to Britain in 1948. And we've had a diverse NHS since its inception. The NHS couldn't exist without the contributions of former British colonies and staff, and that is the linchpin of the NHS. So we have to think a bit more deeply about the overarching system of what's going on, even when you're faced, like I was, with a black midwife. It's much more complicated than that. So diversity is important. Inclusion is important. I think equity is probably more of the actual linchpin and key, and what that looks like. But all of this is underpinned by understanding what anti-blackness and anti-racism is. But I don't want to hog the mic too much, so I will let Annika continue.
Thank you so much.
So good afternoon, everyone. I'm Anika Allen-Gray. So I actually do not work in anything to do with health or motherhood, but I am a head of diversity, equity and inclusion. I've worked in this space for almost 15 years now, mostly in the creative industry, but did have a gap in the finance industry. I always say that I'd say inclusion chose me rather than me wanting to work in this space, because, again, seeing the inequities, the injustices that other people were facing in different areas of work, and I'm the kind of person, I can't just sit back and see something happen and not do anything about it. So I guess that's what kind of ended up me getting into this role and then wanting to kind of drive change in various organisations. I'm a mum of one. It's been amazing hearing kind of the stories here today, because even my experience kind of as a mum, my daughter was born just over a month early. I had preeclampsia. My pregnancy was consultant-led because I have sickle cell anemia, and there's just lots of kind of issues and things. So even from a lived experience, I kind of understand where a lot of people are coming from in this space. And so so happy to answer any questions around kind of things in the workplace that we can do to drive change.
And when we talk about allyship, what does true allyship mean to both of you? Because we were often hearing that. I mentioned that in my opening speech, but what does that actually look like in practicality?
I guess for me, ally is not, you can have an ally, but is that ally being active kind of thing? So for me, it's active allyship in terms of actually listening, learning, but then also taking action, not just kind of sitting back and things. And I think any ally needs to, one, be practicing anti-racism, being vocal about it, speaking up, putting things in place that are needed, speaking up for, if you work in a workplace and you experience any sort of racism and discrimination, that allies should not be just a bystander where they're not doing anything about it. It's about actually being active in your action and saying, actually, no, this was wrong. I'm going to, raise a concern about this if you're experiencing bullying, harassment, etc., and doing something about it, not just sitting back. And so for me, allyship is about taking action.
I love that. Allyship is taking action. Yeah.
So I'm going to start off in a bit of a different place.
Okay.
And this has been such, as I said, a healing space, and it's been so lovely to see so many of you. And Sandra, I forgot to say thank you at the beginning. Thanks for inviting me, and you're also doing incredible, incredible work, and so is your team. But the world is on fire, and it's on fire in a really, really big way. Yeah. And the blowback from what's happening in the US is about to hit this sector of sexual reproductive health, even in this country, really, really hard. And I'm sure some of you have seen what's happened with USAID in the States, but the global ramifications for that in this sector are huge. Like, people's antiretrovirals have gone overnight, and we're going to see the impact, like here, because of migration patterns and so forth. That's going to have really big repercussions, probably for decades to come. And the reason I bring this up is that I think when we speak about allyship, I think sometimes people are thinking of it in a really kind of single individualistic and kind of sometimes often, dare I say it, performative way. But now we really need to think quite deeply about what it means in terms of an overarching structure and thinking about coalition building and deep coalitions. So now that really means people tapping into issues that don't necessarily affect them. Of course, I'm here because the personal is political and all of that. But you need to think well beyond the issues that we're thinking about today and start, you know, making allies in spaces you wouldn't have thought of. Is that climate justice? You know, these kinds of issues and making deep partnerships. And that's the most successful movement. So that's what's about knowing our history. And I don't want to go off on too much a tangent, but some of the best, most effective movements have been deeply embedded with unlikely groups and coalitions. When we look at the civil rights movements, MLK was going off to speak to white workers that were not interested in black issues, and all of that those kinds of things get expunged from the story. You just get the one person and the speaker, right? But now is the time, because the world is on fire, and just talking about having an ally that, you know, people create a niche pot of money, and we really need to think long term and much more complex, and things that are going to go forward for the future, for decades to come. And that means really speaking to people that you thought you would never go and speak to, and seeing what you can align on and what they can do. And that is where we're losing, okay? Because we are going to start losing, and I think we have to be really real about what is coming, especially when we see DEI being shut down left, right, and centre, and what that means. So I don't want to keep going on, but yes, deep coalitions.
And then I have one final question before I open it up to the audience is, how can we create safe environments for Black colleagues and workers?
I guess there's a number of ways you can do that. In the corporate world, you have like employee resource groups. Often that can create safe spaces for people to come together. So often they're based on kind of communities to do with kind of culture. So it might be a Black professionals employees resource group where you can have that safe space to connect and to talk. I think again, it's about people also understanding what's happening within the organisation, because often I think people, you know, particularly senior leaders, can not always understand what's going on in the ground with people in the organisation. So I think in companies, you know, I don't like mentoring, but sometimes maybe reciprocal kind of mentoring in terms of where you're learning from each other. So people from different levels within the organisation. Talking, listening, engaging. Because again, how do you know kind of what the issues are if you're not kind of speaking to people and kind of interrogating what's going on in the business? So I think that's something that organisations can do. And again, speaking to the Black staff as well, and kind of running listening groups and things. Last year I was part of. So the Mayor of London kind of did this thing called a design lab, and so the design lab basically brought together. It had four different sectors. So the health sector, climate, creative, and digital. So I was part of the creative cohort. But essentially, it was about bringing the biggest companies in that sector together to say, how can you collaborate? How can you connect? How can you drive change? Particularly for Black and Asian professionals living in London, because London is a city of hyperdiversity. There's 300 languages spoken in London. We know that ethnic population is bigger in the city, but yet our population isn't the group that are getting the jobs and are having kind of the most negative experiences in the workplace. So it was kind of coming together and say, what can we do to really drive change? So I was part of that creative cohort, but there was also an NHS cohort as well. And so it was about 10 different NHS trusts that came together to work on over 30 different ideas of what they can do in their individual trusts to drive change and to learn from each other. And I think, again, it goes back to what you were saying about that coalition and collaborating, because then people that wouldn't normally have worked together, people that had ideas of things that they were doing in there that were working, then you could apply it to your NHS. Yes. So things like, I remember one organisation had like this thing called letter to the CEO. So again, no hires in senior leadership position got hired until the team wrote a letter to the CEO to say exactly why this person had been hired, had they gone through and looked at it through the lens of kind of diversity, equity, and inclusion as well, and said, did you, was your panel diverse? Did you have a range of CVs? What was that interview process like? And they had to explain exactly that journey it took and why they'd hired this person. And so, from sponsorship programs, there were lots of different initiatives that kind of came out of that program. So it's to say that actually it is about talking to each other. It's not, DEI is a collaborative space, not a competitive space. So again, it's about reaching out to people and just seeing how you can support each other and help.
I love that. Collaborative, not competitive. Perfect. Thank you. And then Annabelle, okay.
Yeah, I think for me, it's really hard to say, but the NHS is far from a safe space. And I work in that system, and we've heard today how, even as black healthcare professionals, we're kind of sometimes complicit in the violence of, that it brings. And it's difficult because I'm working inside the system. And for me, really early on, I established that I had to step outside the system and do community work and find community, because, I decided to not just do community work, but find a collective of like-minded healthcare professionals outside of the system, because I couldn't find them just doing my day-to-day work. And that is the support system that I needed, and that has seen me through my training. So to contextualise, when I went into my training programme, which is very small, there were only 4 training numbers across the UK, and I went to the Midlands for my training, and I've come back to London. I was the first black registrar that they'd had in that programme for 6 years. And I went in to our first meeting of trainees, which was at the Royal College of Obstetrics and Gynecology, and we went into training meeting, and it was kind of shocking. At the time, I had a purple afro. I felt really out of place, and I needed to go outside and find my community. I just wanted to just touch on a few things. Some people might have seen it, but the British Medical Journal did an issue recently on anti-racism and where we are, particularly after all the things of 2020 and the initiatives that people did. And I think one of the things that's really interesting, and there was another article that came out, is that we've had all of these surveys in the NHS for ages about what's happening with the workforce, and they repeatedly show that black staff are suffering, they're not progressing, their mental health is poor, they're having burnout. And it's important to say these same staff, like myself, use the system, don't get treated well, and we are people, right? Yes. And then we have to go into work and enact care, and some of us having other baggage and other things to deal with, and these are same people that want to do better and pushing things forward. And this has been going on for ages. Some of you might know Roger Klein's work, who did the Snowy White Peaks report decades ago. He then did a report when there were the NHS the race riots and how it affected NHS staff, and kind of showing that a lot of things are unchanged, right? So, we have to be honest that the NHS, even for workers, is kind of a site of structural violence, and has been for decades, and we're not really moving forward in the way that we should be. So to get to where we need to be, a lot of staff step outside, and I encourage you to do so, to find communities. There's amazing communities like black midwives and nurses that have been founded, black female doctor, those have all, and people are making their own spaces. But yeah, we have to be real. There's a lot of trauma that continues to be perpetuated in the system, not just on patients, but staff.
Brilliant, thank you. I'm going to take one question. Question at the back.
Lucky I'm right next to you.
Hello, my name's Ria Clark. I am trainee, resident doctor, registrar in obstetrics and gynecology in the NHS. I just wanted to say thank you. Thank you for giving us a space to share these thoughts, because all of the support that I get to enable me to stay in my role comes from outside of my job. Because within the system of the NHS, there are not structures that support the concerns that I have about my training, that support the feelings that I have as a black female doctor working in obstetrics. And whilst I try to be very aware of the fact that I am complicit in the system, and I don't expect sympathy for that because harm comes as a result of that, there is also the unseen that black and brown staff experience every day. And the fact that I have to look outside the system for support is wrong, but the fact that systems like places like this exist are so important. So thank you for creating this space. I know, I agree with you. I absolutely agree with you.
you so much.
Yeah,
I can
thank
see
you.
someone's hand still stretching up. That's really. Is it very short? Yeah? Okay. We're making it on time. We're making it on time.
I'm coming round the back.
Gemma.
I'm coming. Here I am.
Hi everyone, my name's Katie. I am mum to a 2-year-old, suffered with gestational diabetes, perinatal anxiety, maternal sepsis survivor as well. And I'm also, sorry, I get emotional. And I'm also a doctor. I'm a GP trainee.
Wow.
So my question was actually for Annika, because another thing that I do is I've trained as a coach, and I typically work with women who are on maternity leave or going back to work. And given, sorry, ignore the tears, I'm okay. Given like everything we've heard today about all the distressing experiences that women have in general, and particularly black women, going back to work is a really, really tough time. And just from the point of view of, thank you, from the point of view, again, because I work with mums who are going back to work or have recently gone back to work, from the point of view of employee well-being, I know you mentioned some things for, how we're supporting black and Asian professionals, but specifically I just want to know what corporations are doing or can be doing to specifically support mums when they go back to work, given all the experiences they've been through, plus the fact that they're now mums juggling a million different things.
Yeah. So companies can do, again, depending on the budget and what they have, but there are things that they can do for free, right? So just because, times are hard for a lot of companies. So when I went back to Barclays after I'd had my daughter, they had what we called like a buddy system. So new mums that had a child within the last kind of 6 months, like in the last kind of, that come back to work in that 6 months, then we're partnered with that individual. So you could go to them to kind of ask any questions, maybe about any support that the company is providing, or just if you're just kind of having a bit of a meltdown and you needed somebody to speak to, that buddy that you were assigned to could help with that. That's something that companies can easily do for free if they kind of just start like an internal support group. Again, ensuring that any company can have, a room where breastfeeding and expressing mums can go to, to express milk and to have a fridge to put that in. You'd be surprised at actually how many companies still don't have something as simple as that. But again, it doesn't take much to do, to put a lock on a door, to have a fridge there, and to have a private and safe space for mums to kind of go and do that in the office. Coaching, again, like what you're doing, so company paying for that resource for new mums to come back and be coached. Any training that if they have an internal system, great, kind of like signposting to kind of training that can help them kind of just identify any kind of skills gaps, or just get up to date on any kind of research or things that are happening in whichever industry or whichever space you're in. Because often, if you've been, depending on how long you've been on maternity, you'll come back and you'll just feel like you don't know anything and things. So I think just kind of giving that person that grace to kind of learn and catch up, and or invest in kind of sort of training budget for mums coming back into the workplace again, just to kind of just feel that the skills are still there and that they are able to kind of give to that workplace environment. I'm trying to think of other things that I've seen happen that have worked well. When I was at Barclays, one of the things that I created was a Women at Barclays portal, because again, we had this really complicated intranet where you could never find anything. And it was like, actually, let's kind of just create a portal where everything is there. So regardless of what life stage you're at, that you could find that information. So whether it was you're pregnant, whether you're coming back as a new mum, whether you're going through the menopause, and sometimes it's just about having that information in the right space. So when you go back and you've got a million other things to think about, like who's picking up the child from nursery, or whoever's looking after them, you've got all these things on your mind, so you just want things just as simple and easy as possible. So I think there's sometimes just really breaking down the systems and just making things easier. And if your workplaces don't have things in place, one of the things I would say is just workshop it, literally get people from different backgrounds, different levels in the business to talk about what the issues are, what the challenges are, and what's practical within your organisation to implement. Because I say these things, but depending on your industry, depending on your organisation, depending on the money you have, some things would be the organisation can do, some they can't. But it's about kind of what you can make work in your organisation.
Brilliant. Thank you so much. Thank you guys for such a wonderful panel discussion. Please, guys, give me a round of applause for Annika and Annabelle. You guys are amazing. Thank you.